Imagine experiencing a pain so severe in your jaw, like so sudden and electric, that you were just convinced your teeth are rotting out of your skull.
Right.
So you rush to the dentist, they do an extraction, you wait weeks to heal, and the exact same agonizing shock returns.
Right.
So they pull another tooth and another. Until finally, someone realizes the teeth were never the problem at all. Welcome to our deep dive. Today, we are decoding the completely invisible language of the nervous system.
Yeah, and that dental story, it is just a profound failure of translation, really. Because when a patient walks into a clinic with a neurological issue, the terminology the doctors use, words like hemiplegia or radiculopathy, it can sound like this impenetrable wall of Latin and Greek.
Oh, totally.
It honestly sounds designed to keep non-doctors out.
It is super intimidating.
Yeah.
But in this deep dive, our mission is to show you that medical jargon isn't about rote memorization. It is actually this highly logical, easily decodable system. Because once you understand the architectural rules behind these words, you realize they aren't just, labels. They are precise diagnostic maps.
They absolutely are. If you understand how a neurological term is built, you basically understand exactly what is failing inside the patient's body. So today we are going to break down two heavy-hitting concepts, which are paralysis and nerve pain.
Right.
And we will explore the history behind the language, the high-stakes medical debates, and the literal word-building formulas that make these terms work.
Let's start with the architecture itself. Because to understand complex conditions, you first have to understand the medical syntax. I like to think of it like a set of Lego blocks.
I love that analogy.
Yeah, so you have three main types of pieces you can snap together to build a diagnosis. A prefix, which tells you how much or where. A root, which identifies the body part. And a suffix, which tells you what went wrong.
Exactly. And when you apply that Lego system to our first major category, which is paralysis, the terminology essentially writes itself. Let's take a widely used term like hemiplegia and just pull it apart.
Okay.
So the prefix hemi is Greek for half.
Right, like a hemisphere.
Exactly, hemisphere. And the suffix plegia comes from the Greek word plege, meaning a blow or a stroke. So if you literally translate it, hemiplegia means half struck down.
Half struck down. I mean, that is a brutal but incredibly accurate way to describe a stroke.
It really paints a vivid picture, doesn't it?
Yeah.
Clinically, it refers to the total or near total paralysis of one lateral half of the body. So one arm, one leg, and often the lower face on that same side.
Got it.
And it happens when there is catastrophic damage somewhere along the motor pathway, basically anywhere from the cerebral cortex in the brain down through the brainstem.
But wait, if we are treating this terminology like an exact science, what about patients who just have, a weak arm after a minor stroke? If they aren't totally paralyzed, are we still snapping on that plegia Lego block?
Oh, you have just hit on a massive point of friction in modern medicine. Yeah, the purest debate. Because strictly speaking, in classical neurology, plegia means the complete loss of voluntary movement, total paralysis. If a patient only has partial weakness, the correct suffix block to snap on is paresis.
Paresis?
Right, which means a slackening. So they would have hemiparesis.
Okay, but I imagine an emergency room is way too chaotic for people to be policing Greek suffixes, right?
Oh, it is extremely messy in practice. Today, in chart notes, patient handoffs, and even textbooks, hemiplegia is routinely used as a loose umbrella term covering, any degree of one-sided weakness.
Wow.
It drives medical purists crazy, but the linguistic drift is so common now that major stroke rehabilitation literature has to explicitly flag the distinction. They literally have to tell clinicians to actively relearn the difference.
Because the physical therapy would be different, right?
Exactly. Treating complete paralysis requires a very different rehabilitation strategy than treating residual weakness.
So precision actually dictates the physical therapy.
That makes total sense. Let's look at how this Lego system works geographically, with prefixes. If we lock in that plegia suffix for paralysis, and we look at the spinal cord as a sort of fiber optic highway, the prefix we choose tells us exactly where the highway was severed, right?
That's a great way to visualize it. The spinal cord is a highway with specific off-ramps for different body parts.
So if a doctor says a patient has paraplegia, the para prefix means beside or two similar parts, so that's both legs, meaning the off-ramps for the arms must be completely untouched. The damage is lower down the highway.
Precisely. Paraplegia typically results from a spinal cord injury below the neck. So if someone is in, say, a motorcycle crash and fractures their T10 vertebra.
Which is right in the middle of the back.
Right, the middle of the back. The lower highway is cut, the the legs are paralyzed, but the nerve off-ramps for the arms, which exit higher up in the cervical spine, they remain fully functional.
But if the damage is higher up, say the neck, you swap the prefix to quadra or tetra, 4, quadriplegia. Right, paralysis of all 4 limbs. This happens from a high cervical spinal cord injury, specifically damage to the C1 through C4 vertebrae in the neck. The actor Christopher Reeve's tragic horse riding injury is the most famous example of this.
Yeah.
The severing happened so high up that all the motor off-ramps below it were disconnected.
And what if the damage isn't a severed spinal cord at all? What if it's a very specific, localized brain injury? Say, just one limb is paralyzed.
Then you snap on the monoblock, monoplegia.
Okay.
This is relatively rare, actually, and usually points to a very focal lesion in the cortex of the brain, maybe a tiny stroke or a tumor that only wiped out the specific cluster of neurons controlling, say, the right arm.
Got it. There's one more prefix I want to ask about because it seems to have a lot of historical weight attached to it, which is dija, meaning two, diplegia. It implies symmetric involvement, like both legs equally, right?
Yeah, diplegia is fascinating because it forms the historical foundation for how we understand cerebral palsy today.
Oh, really?
Yeah, in the 1850s, an English orthopedic surgeon named William John Little started documenting cases of children with severe, lifelong limb stiffness and paralysis, mostly affecting both legs symmetrically. Spastic diplegia.
And he was the first to connect the physical paralysis to the actual birth process, right?
He was. Little wrote a landmark series of papers linking difficult oxygen-deprived births to this specific pattern of brain damage. For a long time, the condition was just called Little's disease. He used the concept of diplegia to track the physical symptom back to a highly specific mechanism of injury.
So that's what happens when the neurological highway is completely cut off or damaged at birth. We get this whole family of paralysis terms.
Right.
But what happens when the highway is just damaged, and instead of stopping in the signals entirely, it starts, amplifying them into excruciating pain?
Then we put away the plegia suffix, and we bring out algia.
Algia, the suffix for pain. And if we snap on the root neuro, meaning nerve, we get neuralgia, literally nerve pain. But we aren't talking about a dull, achy muscle after the gem, are we?
Not at all. Neuralgia is severe, sudden, shock-like pain. The clinical term is paroxysmal. It's a pain that travels along the exact anatomical distribution of a specific nerve. Honestly, it feels like getting hit with a taser from the inside.
Wow. Which brings us back to that nightmare dental scenario we started with. If a patient comes in with electric shock pain in their jaw or cheek, what nerve is causing that?
That is trigeminal neuralgia. The trigeminus is the 5th cranial nerve, and it's massive. It exits the brainstem and splits into 3 distinct branches, hence trigeminal.
Ah, that makes sense.
Yeah, and they supply sensation to your upper, middle, and lower face.
So when that nerve misfires, the pain maps perfectly to those specific branches.
Exactly. And the nerve becomes so hypersensitive that the excruciating shock can be triggered by almost nothing. Chewing food, brushing your teeth, or literally just a cold breeze hitting your cheek.
Ah, that explains the dental misdiagnosis perfectly. The pain shoots down the mandibular branch of the nerve straight into the jaw. The patient feels tooth pain. The dentist assumes it's a bad tooth, and they just start extracting.
It is a genuine diagnostic trap. It's what we call the geographic illusion. The clinician anchors on the most obvious anatomical location, the mouth, instead of recognizing the characteristic mechanism of the pain.
Right.
The fact that the pain is sudden, electric, and triggered by light touch should scream neuralgia, not cavity.
What about pain that lingers after an infection? Like shingles. I know that virus attacks the nerves directly.
Yes, that leads to postherpetic neuralgia. Post meaning after, and herpetic referring to the herpes zoster virus, which is what causes chickenpox and shingles. After you recover from chickenpox, the virus never actually leaves your body. It hibernates in your nerve roots for decades.
Just waiting.
Exactly, just waiting. And if your immune system weakens later in life, the virus wakes up, travels down the nerve fiber, and causes the shingles rash.
Oh, wow.
And postherpetic neuralgia is the burning, relentless pain that lingers in that specific band of skin for months or even years after the rash itself has completely healed. The virus essentially scorched the earth on its way out, leaving the nerve permanently irritable.
Are there other specific nerves that fall victim to this?
Oh, absolutely. If you swap the root block, you can map pain anywhere. So occipital neuralgia is sharp, radiating pain from the base of the skull up over the back of the head.
Ouch.
Yeah. Glossopharyngeal neuralgia, glossa for tongue, pharynx for throat, is a rare condition where just the act of swallowing triggers severe throat and ear pain. And intercostal neuralgia affects the nerves running between your ribs, often following chest surgery.
It makes me wonder how doctors navigated this before the linguistic Lego system existed. I mean, people have been suffering from trigeminal neuralgia for thousands of years. If you were a doctor in the 1700s, how did you even describe a patient whose face was in agony?
Very vaguely, and usually by just naming it after whoever wrote a good paper on it.
Right.
The clinical picture was well documented, but the terminology was a mess.
I read that trigeminal neuralgia used to be called Fothergill's disease.
Right. An English physician named John Fothergill wrote a brilliant, vivid description of this painful affection of the face in 1773. So for a century, British doctors just named the disease after him. Meanwhile, over in France, a surgeon named Nicolas André had coined the term tectic douloureux in 1756.
Which translates to painful twitch.
Yes, because sufferers would physically flinch and wince with every jolt of pain, but both of those names, Fothergill's disease and cot douloureux, they're just descriptive labels. They don't tell you why it's happening.
So when did we finally get the word neuralgia? Like, when did the medical field realize they needed a word that explained the actual mechanism?
The turning point was 1801. A French anatomist named François Chassier was dealing with a patient who had severe rib pain. He realized that painful twitch, or a doctor's last name, just didn't help him understand the anatomy.
Yeah.
He needed a clean way to describe pain traveling along a specific nerve pathway. So he combined the Greek roots for nerve and pain and coined neuralgia. And the neologism caught on across Europe instantly.
Because it wasn't just a label, it was an explanation. It said, this isn't muscle pain, this isn't bone pain, this is nerve pain.
Exactly. And we see a parallel evolution with the paralysis terminology. Hippocrates was describing one-sided apoplexy back in 400 BCE, but the term hemiplegia was modernized and really weaponized in the 19th century by heavyweights like Jean-Marc Charcot in Paris and John Hewlings Jackson in London.
What you say weaponized? How so?
Because they used the terminology to map the brain before neuroimaging existed.
Oh, wow.
Yeah, Charcot was working at the Salpêtrière Hospital observing thousands of patients. He realized that by mapping exactly which muscles were paralyzed, using precise terms like hemiplegia or monoplegia, he could accurately predict exactly where the brain lesion was located before the patient even died and had an autopsy.
That is incredible. They were using the physical symptoms as a reverse-engineered map of the brain.
They called it a localizing sign. Because the motor pathways cross over in the brainstem, specifically at a structure called the medullary pyramids. Damage to the right hemisphere of the brain causes paralysis on the left side of the body. Charcot and Hewlings Jackson used this precise language as a tool to see inside the living brain.
But with that level of precision comes the danger of misusing the terminology, right? We talked about the dental failure mode, where a dentist pulls a tooth because they don't recognize neuralgia. But what about the broader terms? I constantly hear people at the gym throwing around words like neuropathy or radiculopathy.
They usually use them wrong, which blurs the clinical picture. Let's delineate them. Neuralgia is the symptom, the acute electric pain running along a nerve pathway. Neuropathy, on the other hand, is the broader disease state describing any nerve damage or dysfunction.
So you can have neuropathy without having neuralgia?
Absolutely. Think of diabetic neuropathy. The high blood sugar damages the nerves in the feet. The patient might experience numbness or a loss of sensation entirely. Their nerves are diseased, so they have neuropathy, but they aren't necessarily experiencing the shock-like pain of neuralgia.
Okay, that makes sense. And what about radiculopathy?
Radiculopathy refers specifically to a mechanical compression at the nerve root, right where it exits the spine. The most common everyday example of this is sciatica.
Oh, sure.
Yeah, a herniated disc in your lower back pinches the nerve root and the pain radiates down your leg. The issue is at the spine, but you feel it in the limb.
Let me push back on something we discussed earlier. We framed hemiplegia being half struck down as the result of catastrophic damage to the motor pathway, like a stroke or a tumor. That implies permanent structural brain damage. Is it always permanent?
It is entirely logical to assume it is, and most people do, but no.
Yeah.
And this is a genuinely terrifying diagnostic challenge for doctors. Hemiplegia can be temporary.
Wait, really? You can be completely paralyzed on one side of your body and then just...
Get better, yes.
That's crazy.
There is a rare genetic condition called familial hemiplegic migraine, or FHM. As part of their migraine aura, literally before the headache even hits, these patients experience severe, temporary, one-sided weakness. It looks exactly like a massive stroke.
That has to be horrifying for the patient.
And completely panic-inducing for the ER physician. There is also a phenomenon called Todd's paralysis, first described by Robert Bentley Todd in 1849. After a patient has a severe epileptic seizure, the brain essentially suffers an electrical exhaustion.
Okay.
The patient can wake up with profound one-sided paralysis that lasts for hours, sometimes up to a day, before fully resolving on its own.
So if a patient is brought into the ER with sudden hemiplegia, the doctor has to figure out on the fly if it's a permanent stroke where they need to administer clot-busting drugs immediately, or if it's a migraine or post-seizure paralysis that will just fade away naturally.
Exactly. It completely disrupts the idea that paralysis equals permanent structural damage, which leads us to the ultimate question. If these symptoms aren't always caused by a severed wire or a dead patch of brain, what microscopic mechanisms are actually causing these extreme reactions?
Right. Why does a nerve suddenly start firing off taser shocks to the jaw?
That specific question sparked one of the biggest scientific debates of the 20th century. In 1934, a neurosurgeon named Walter Dandy noticed something peculiar during his operations on trigeminal neuralgia patients. He saw that a blood vessel was often physically pressing against the trigeminal nerve root right near the brainstem.
It was compressing the nerve?
Yes, but the medical establishment mostly ignored him. It wasn't until the late 1960s that another neurosurgeon, Peter Janetta, championed this vascular compression theory. Janetta developed a surgical fix called microvascular decompression. You open the skull, find the artery pressing on the nerve, and you literally just slide a tiny Teflon pad between them to cushion the nerve.
It sounds remarkably simple, like fixing a rattling pipe under a sink.
It does, but it was hugely controversial. Because as MRI technology advanced in the following decades, critics pointed out a glaring flaw in Janetta's theory.
Let me guess. They scanned healthy people and found the exact same thing.
Exactly. You can look at an MRI of someone who has absolutely zero facial pain and see a blood vessel heavily compressing their trigeminal nerve. So physical compression alone cannot be the sole cause of the pain. If it were, everyone with that anatomy would be in agony.
So what's the missing link? If the artery pressing on the nerve isn't enough to cause the pain, what tips the scale?
The current consensus is a hybrid model involving the myelin sheath. Myelin is the protective, fatty insulation wrapped around our nerve fibers. The theory is that the constant localized pounding of the pulsating artery eventually wears away that insulation. It causes localized demyelination.
So the wires are stripped bare.
Exactly. And when those bare, uninsulated nerve fibers are exposed to each other, they start misfiring. An electrical signal traveling down one fiber jumps across and triggers the neighboring fiber. This phenomenon actually has a name. It's called ephaptic transmission.
It's literally like crossed electrical wires sparking inside a wall.
That is the perfect analogy. A normal touch signal, like a breeze on the cheek, travels down its designated wire. But because the insulation is gone, the signal jumps the gap to a pain wire. That microscopic short circuit is the agonizing shock of neuralgia.
And what I find absolutely brilliant is how this exact cross wires mechanism explains the benchmark treatment we use today. Because it wasn't invented for pain at all.
You're talking about carbamazepine.
Yes. In the 1960s, a Swedish physician named S.G. Blom made this incredibly elegant, logical leap. Carbamazepine was developed as an anti-epileptic drug to stop seizures.
Right, because a seizure is essentially a massive electrical storm in the brain. Overactive, misfiring neurons.
Exactly. So Bloom reasoned that if trigeminal neuralgia is also just an electrical storm, misfiring neurons sparking against each other in the nerve root, maybe a drug that calms brain sparking could calm nerve sparking.
It was a stroke of genius. He tested carbamazepine on neuralgia patients, and the results were staggering. It quieted the nerve instantly. It was adopted almost by accident, and yet 6 decades later, it remains the absolute first-line pharmacological treatment for trigeminal neuralgia, a total repurposing success story.
It just highlights how interconnected the nervous system is. We see this with stroke symptoms, too. When someone suffers from hemiplegia, it rarely exists in a vacuum. It often brings along neighbors.
Very true. Because of the brain's geography, certain symptoms bundle together. If a stroke damages the left hemisphere of the brain, causing right-sided hemiplegia, it very frequently wipes out the language centers as well, causing aphasia.
Because the motor cortex for the right side of the body sits right next door to Broca's area, which is the speech center.
Precisely. This goes all the way back to Paul Broca's famous patient in 1861, a man named Louis Victor Le Borgne. He was nicknamed Tan because that was the only syllable he could speak.
Right.
Yeah, he had severe expressive aphasia, but he also had right-sided hemiplegia. The lesion in his left hemisphere was large enough to knock out both systems. You also frequently see hemianopia, the loss of half the visual field, bundled with these strokes.
So as we zoom out and look at all of this, why should someone without a medical degree care about mastering these terms? Why is it important for you, the listener, to know what hemiparesis or postherpetic neuralgia means?
Well, because the public health implications are massive and the clock is always ticking, we have a rapidly aging global population. Stroke is one of the leading causes of long-term adult disability worldwide.
Which is exactly why public health officials push the FAST acronym on billboards everywhere. Face drooping, arm weakness, speech difficulty, time to call 911.
Exactly. Recognizing that sudden one-sided weakness, that hemiparesis, and acting immediately dictates whether a patient recovers or requires lifelong care. Time is brain. And when it comes to nerve pain, specifically postherpetic neuralgia from shingles, we are dealing with a growing, debilitating issue stemming from a virus that is entirely vaccine preventable.
The stakes are life and death. I mean, the medical community literally refers to trigeminal neuralgia as the suicide disease because the unrelenting, unpredictable nature of the pain drives patients to absolute despair.
Which is why the terminology matters so much. Fast, accurate diagnosis saves a patient from the dental failure mode. It gets them out of the dentist chair and into a neurologist's office for carbamazepine. The words we use dictate the treatments we provide.
Before we wrap up this deep dive, I want to leave you with a thought about that MRI paradox we discussed earlier.
The fact that you can have vascular compression without any pain.
Yes. Think about the profound mystery in that. Two people can walk into a clinic, they can slide into an MRI machine, and both scans will show the exact same physical anomaly, a blood vessel heavily crushing the trigeminal nerve. Yet one person will go about their entire life completely pain-free, totally unaware it's even happening.
Yeah.
The other will experience the most excruciating, shock-like agony known to human medicine.
It really suggests we still don't have the complete picture.
It forces you to wonder, what is the invisible microscopic threshold that exists within our nervous system? What biological switch decides whether our own personal crossed wires remain safely insulated and silent or degrade into unbearable pain? It just goes to show, as much as we've decoded the Greek and Latin syntax of the human body, the nervous system still holds secrets we are only just beginning to translate. Next time you hear a doctor use a word like hemiplegia, remember, it's not a barrier designed to keep you out. It's a map. And we are still exploring the territory.